So today we're going to be talking about schizophrenia and other psychotic disorders. When I was doing my internship, which is the year before you receive your PhD after you have completed all your coursework and your dissertation, I worked in an inpatient psychiatric facility as well as an outpatient clinic that was associated with the hospital. And most of, and if not all, my caseload were individuals who'd been diagnosed with a schizophrenia spectrum disorder. And this was a drawing that one of my patients made for me, and I found this was to be very significant because he told me that this is what he sees inside his head. And like, take a minute to look at this drawing. I find it very powerful. One of the key themes that you notice probably is that there are eyes throughout this. And this is a common theme that I've seen throughout the artworks of many of my patients throughout the years, is this eyes. And, you'll often hear people who have schizophrenia, they're somewhat paranoid, so it could be the belief that they're being spied on, for example. There's also religious imagery. You can see a picture of Jesus in the upper right-hand corner, as well as kind of drug paraphernalia at the bottom with some mushrooms, and it looks like a bong down there. And this patient in particular was self-medicating with marijuana. Other patients have told me that they feel like their schizophrenia came after they were experimenting with drugs. There is some research evidence to suggest that, especially hallucinogens can precipitate a psychotic episode for those people who are, genetically predisposed to be having one anyway. So it can kind of put you over the edge, but it's not clear or certain. But I've always loved this beautiful picture, and I think it's very, as I said, emblematic of what goes on in the head of somebody who has a schizophrenia spectrum disorder. So just to give you a little background, Kraepelin, who is a psychiatrist, was the first one to differentiate schizophrenia from manic depressive disorder. Previously, they were kind of grouped together, and he called it dementia praecox, which meant that it was early onset dementia, basically a dementia that started in early adulthood. And you'll see that patients with schizophrenia often develop their symptoms in early adulthood. And then he felt that their cognitive functioning and intellectual functioning was decreasing over time, and that this was organic in nature. Bleuler, who is also a Swiss psychiatrist, also studied what we now know as schizophrenia, and he was the first to call it schizophrenia, which he referred to as split mind. You'll see that because of this kind of split mind, that often people still today confuse multiple personality disorder with schizophrenia because they feel like there's the split in multiple personality disorder, which is emblematic of the multiple personalities, but really it developed here because Bleuler felt that it differentiated the emotional and the cognitive mind. So he, separate from Kraepelin, didn't feel that it was necessarily a disorder that happened in young adulthood. As we know, for some it can happen later on in life, although the predominant onset is around kind of 18 to 22, especially for men. And that it's not necessarily a deteriorating condition, which is kind of what somewhat supported. We don't see people necessarily getting worse. We see kind of ebbs and flows throughout the lifespan. So some of the fundamental symptoms he noted were the loose associations, affective indifference, so that there's really kind of a lack of expression, ambivalence generally, that they don't really care about a lot of things. There's a lack of motivation, and autistic-like experiences where they seem very focused in their own head, and especially if they're experiencing hallucinations and delusions, you'll see that that's often common. So he felt the fundamental symptoms were this ambivalence and this autistic detachment, and that was what characterized somebody with a schizophrenia. Um, he felt like symptoms that we traditionally today associate with schizophrenia, like delusions and hallucination, were accessory symptoms, and they were not necessary for diagnosis of schizophrenia, although, as you'll see when we go through the diagnostic criteria, they now are. Today, we generally separate the psychotic symptoms of these psychotic disorders into positive symptoms and negative symptoms. So the positive ones are generally things that are affecting behavior or thought processes, such as delusions, which I'll explain in a second, hallucinations, disorganized thinking and speech, and abnormal motor behavior. So you'll see some strange, like arms being held in very strange or awkward positions, or very saccadic motions. Negative symptoms look a lot like a severe depressive episode. So you'll see diminished emotional expression, avolition, lack of motivation, anhedonia, inability to experience pleasure, alogia, diminished speech output, or asociality, the lack of desire to socialize. And so a lot of these you can see look like symptoms of depression. So oftentimes people who present as more with the negative symptoms, and especially if they're not actively psychotic or reporting hallucinations or delusions, can get diagnosed with a severe depressive disorder. Sorry. I don't know why my computer does this periodically. All right. So delusions, and I apologize for the first line here, are fixed beliefs that will not change even if there's no evidence. So one of my patients once told me that he believed that the FBI had implanted an electrode into his penis and was spying on him as a consequence of that. Now, even if I had performed psychosurgery and looked inside his penis and shown to him that there was no electrode implanted there, he still would not have believed me. It's not like the cognitive distortions that you see with somebody who is depressed. These often, despite evidence, will not change. The content of these delusions can be varied. For example, erotomania is the delusion that another person is in love with you. It's usually a higher status person. So oftentimes when we see these celebrity shootings, it's because somebody has an erotic delusion. They believe that a celebrity is in love with them and that they've somehow been snubbed by this celebrity. You'll see that people fall in love with presidents. Grandiose delusions are delusions of inflated worth, power, knowledge, or they have a special relationship to a deity or famous person. I've met on several occasions Bill Clinton's girlfriends, and I say that in quotation marks. These were women who believed that they were dating Bill Clinton, who was more famous at the time when I was doing some of this work. And I also have met many people who are living on the street, but yet are billionaires. They've developed very, famous inventions. Jealous delusions is kind of like the single white female where the individual's sexual partner is unfaithful to them. Persecutory delusions, and that's above and beyond kind of regular jealousy. This is to the point where it becomes there's no evidence to the contrary. And the person becomes obsessed with this. It will ruin relationships and can result sometimes in violence and stalker-like behavior. Persecutory delusions, this is where the FBI, the CIA, some other entity is spying on you. And then a somatic delusion, which has to be separated from a somatoform disorder, is where there is some physical defect or general medical condition. But you'll see, as I give you some examples here, that the content is very different from the somatoform disorder. For example, like an alien has removed your pancreas, or that you emit a foul odor, but there's no, odor there, that there are bugs under your skin, that you have an internal parasite, but there's no evidence of that, or body parts are malfunctioning and there's nothing to support that. Hallucinations are perceptual experiences without external stimuli. So these can occur in any sensory modality. They're typically auditory, but we can also have visual, gustatory, and tactile hallucinations. Um, One of the key features of hallucinations is that there's lack of control. So disorganized thinking and speech is also a function of, sorry, of those with schizophrenia, and so it's commonly referred to as a thought disorder. So here is a YouTube video of an individual who's posted a video of himself talking, and he has loose association. So you can see, well, there is something that makes sense. It's not quite entirely cohesive. So I'll play a little bit of that for you if we can get that going here.
Okay, so the project is reaching its next milestone. I'm writing the last of the web pages to distribute it. I have no money to advertise it with. I think I can be done with all this sometime next week or early the week after, and then got to start job hunting. And I think I brought up my stepmom's website. She got sick of me doing laundry over at my dad's, so she bought me a washer dryer, and I applied for my first job a week ago today, last Wednesday. And I find out the next morning, I go over to my dad's and he says, well, she wants a website in exchange for the washer dryer. I'll throw in $300. Will you do it? And of course I say yes, because he's done so much for me. And now I know I brought this up. And so that is, I'm probably willing to put in as much as 3 weeks of full-time work into that. And if I get a half-time job, that's 6 weeks that I'll spend away from my project. So I wanted to at least get it in a state where I could distribute it and keep track of the people who used it, grant them administrations for the tests they published and things like that. And huh, that's really about all there is to say. My drunken neighbor is acting up tonight. He he doesn't like me. I think that he liked me at first when he thought I was just some degenerate schizophrenic who had nothing going for him. But as it became clear that I was a computer programmer and other things, he really began to dislike me. And I hope that doesn't sound too arrogant, but I think it really bothers him. I think there are other people too around here who probably liked me better when they thought I was just some, well, maybe I'm being too cynical. I don't think so. Yeah, it's like a documentary I saw on racism. This guy tells a story of his father who, their neighbor, they lived on a farm, and
All right, so forgive me for these things popping up on my computer all the time. So you could see from that video, while there was some train of thought, it was very loose. He jumped from one topic to another. The thoughts didn't progress in a logical way. What was also interesting, if you were able to observe him, you could see what he was doing with his mouth and his tongue, and that's a extrapyramidal side effect of some of the antipsychotic medication. You'll often see people in mental hospitals doing what's called the Haldol shuffle, that they have difficulty lifting their feet up. So what had happened with the old school antipsychotics is that it depleted dopamine and then gave people symptoms of Parkinson's disease. You'd also see kind of the deadness behind his eyes, which is kind of probably a byproduct of the antipsychotic medication that he's on. So that is an example of loose or tangential speech. Also, you'll see commonly things such as word salad. So these are common words that are linked together in an unintelligible manner. You don't necessarily immediately know that things don't make sense, but they've said something, and then you kind of think back and you're like, that absolutely makes no sense. Like the sheep language, blue trains suffer, or windows, books, dogs ran hard. So those are all words that make sense, but they don't make sense together. Some of the abnormal motor behaviors that we can see catatonia. There was a movie with Robin Williams called Awakenings, probably about 20 or 30 years old now. I don't know, it's probably before your time, where they had patients who were in this catatonic state where they just basically are not moving, they're not responding, can move their arms, and they just stay there. It can be associated with extreme negativism. There's mutism, catalepsy, so they'd be holding odd postures or positions. You can sometimes see catatonic excitement, whereby you have extreme movements. And then you'll also see things like echolalia or echopraxia, where they repeat what you say. Again, we talked about the negative symptoms, the diminished emotional expression, the avolition, which is the lack of motivation, alogia, poverty of speech, anhedonia, the lack of interest and pleasure, and the asociality, which is the lack of desire to socialize. So again, a lot of this can be confused with symptoms of depression. So in order to be diagnosed with schizophrenia, you have to have two or more of the following symptoms for a 1 month period. Delusions, and it has to at least include delusions, hallucinations, or disorganized speech. And you have to have two of those, or grossly disorganized or catatonic behavior and negative symptoms. There has to be a change in areas of functioning, so that's the clinical significance criteria. So they are having difficulty with their social work and self-care. Self-care is quite evident. You'll see people often don't bathe. They become, quite stinky. It's not uncommon for people to start not caring. It's one of the first signs that you'll see. And this has to be going on for at least 6 months. And that's the key distinguisher here between some of the other disorders. So, a delusional disorder is one or more delusions with at least 1 month in duration and no other psychotic symptoms. So, they would have delusions, but they wouldn't have hallucinations, disorganized speech, disorganized behavior, or negative symptoms, just these delusions. They've never met criteria A for schizophrenia, so they wouldn't have two of the three of those three things. The functioning is not markedly impaired and behavior is not obviously odd or bizarre. So often people can have delusions. Like there was once this librarian who believed that people were stealing her thoughts at night, so she would sleep with a metal thing on her head. But if you didn't know to ask about that, she was still functioning very well in all aspects of her life, but she was sleeping with some sort of metal thing on her head because she believed that her neighbor upstairs was stealing her thoughts at night. If manic or depressive episodes have occurred, they have to be brief with relation to the delusional episodes, and you have to separate out this is not some sort of psychosis related to mania or extreme depression. Then you want to specify whether it's erotomanic, grandiose, jealous, persecutory, or somatic, which is how we talked about. If it's first or multiple, and the severity of it. So 0 is not present and 4 is severe. So a brief psychotic disorder is basically the same thing as schizophrenia in many aspects. However, you only need one of the symptoms, but it has to be 1, 2, or 3. So schizophrenia required 2. And the duration had to be at least 1 day, but less than 1 month, with eventual full return to normal premorbid functioning. And you have to specify if it's with or without marked stressors or postpartum onset or catatonia, and you again assess the severity. I saw a young man when I was on my internship, and he was diagnosed with a brief psychotic disorder. He had shot a dog, and for about a period of a week, believed that the dog was infested with by the devil, and therefore he had to kill him because the dog was the devil. But then after this 1 week period, he returned to normal functioning. He knew what had happened, but he couldn't explain why it happened. And I felt very bad for him because he was on the inpatient ward for months at a time. Schizoaffective disorder are the presence of delusions or hallucinations for 2 or more weeks in the absence of major mood episodes during the lifetime duration of the illness. And so these are people who vacillate between um, depression and psychosis, but the psychosis happens when there is no depression. So that's like the key distinguisher from a psychotic depression, because somebody who is psychotically depressed has depression, which then becomes psychotic, but they're still depressed. Somebody with schizoaffective disorder vacillates between these psychotic symptoms and the depression. You have to have a good life history in order to diagnose someone with this, because it's very hard to separate whether they have psychosis and depression. And so I see this kind of as a catch-all diagnosis, because a lot of people with schizophrenia happen to have depression as well when they have periods of lucidity. And so you'll see that people will diagnose them with this, but it's not necessarily an accurate diagnosis, but one because they have both depression and schizophrenia. So schizophreniform disorder basically is schizophrenia, but it's less than 6 months. So it could be kind of, we're really not sure about this disorder. Some people believe it's like a precursor to schizophrenia, but again, it's 2 or more of the symptoms. It has to be 1, 2, or 3, but it's less than 1 month in duration. And they don't have to have the impairment in functioning that you see with schizophrenia. So there are tremendous costs associated with schizophrenia, generally because it's a lifelong illness in many cases, requiring inpatient hospitalization at times, very expensive medications to treat. That it's associated with tremendous costs to healthcare, loss of productivity, and mortality. It's estimated that about 0.7% of the U.S. population has it, but they find that it's less prevalent in Europe. But that's probably largely due to the way people are diagnosing, with mood disorders more frequently diagnosed in Europe, in the UK, as opposed to schizophrenia in the US. It's stable across diverse populations, and it's roughly about 1% globally, although we see it higher in low SES individuals. So one of the this suggests two things. One is that there is something biological, since we're seeing it across the world, across cultures, things like that, that it's not a cultural syndrome. And the fact that people have lower SES is often due to the fact that people who have schizophrenia often can no longer work and function. They are asocial, so they kind of neglect their families, and therefore they kind of go to the lower strata of the SES spectrum. Therefore, if they tend to have children, their children might get taken from them. They're put in foster care, and then they have a higher rate of or higher chance of having a schizophrenia spectrum disorder because their parent did. So it kind of perpetuates the cycle. We see higher rates in African Americans and Latinos. One of the thoughts for that is that there's just diagnostic variability, that people are more likely to diagnose schizophrenia in somebody of African American or Latino heritage. We do see that males are more often diagnosed with schizophrenia than females, and they think it's because estrogen serves as a protective factor, although women can have schizophrenia as well. We see a more severe course in industrialized societies, and I think that's because in less industrialized societies, people tend to live with their family members and they kind of protect them and keep them safe, and less is expected. And here we don't have as much kind of familial infrastructure in place, and people tend to end up on the street. And we see that people tend to gravitate to urban environments where there's more environmental stressors. A lot of comorbidity with substance abuse, as you saw in the diagram. People will self-medicate. Oftentimes they'll get off their meds and they will self-medicate with street drugs. About 20% of people with schizophrenia will attempt suicide. 10% succeed in the first 10 years, and the overall rate is about 6%. So it's a relatively high rate of suicide. That's either because of when in periods of lucidity they recognize what has become of their life. In other cases, it's also because they have command hallucinations that are telling them to hurt themselves. It's estimated that up to a third of the homeless population may have schizophrenia diagnosis. People have associated schizophrenia with violence, although the two are not, they're necessarily equatable. Just because somebody has schizophrenia doesn't mean they will not be violent. However, because of the nature of these command hallucinations where the voices tell them to hurt themselves or somebody else, they may engage in violent behavior even though they're not violent individuals. So in terms of where they live, we see 6% are homeless or live in shelters. 6% are in the jails or prisons, which is a big problem. They've closed a lot of mental hospital beds over the last 5 decades, and as a consequence, the jail population prison and jail population has skyrocketed with those with persistent mental illness. 5 to 6% live in hospitals, 10% live in nursing homes, 25% with a family member, and 20% live in supervised housing. Generally, we see the onset between 16 and 25 years of age. Those who have a later onset have a better prognosis. And those where the onset is very rapid generally have a better prognosis for those than there's like a gradual onset. We call this gradual onset the prodromal stage, which is when it happens in like generally mid to late adolescence, where there tend to be more odd behaviors. So you'll see people kind of withdrawing. There might be some odd thoughts, but you don't necessarily, it's hard to separate from normal teenage behaviors. But two-thirds have moderate to severe courses where they're significantly affected by the psychosis and that impacts their quality of life. Those that have better outcomes have lower family members with lower expressed emotion, which we'll talk about momentarily. They have higher levels of social skills before the onset of the disorder, and they have higher levels of social support, and their family members are helping them and keeping them on their medication and treatment. So you can see here, there's just the age of onset. This is a disease that kind of comes on among young men, so that 18 to 22. So you'll often see it happening while men are away at college because the families are not there. They may have their first break during this point. With women, you can see still primarily younger women are getting it, but you see that there's higher rates of women are getting it later on in life, and that's when you see the decrease in estrogen. And so it's possible that, as we talked about, that the estrogen serves as a protective factor for this psychosis. We don't know exactly what causes schizophrenia. It's thought that it's a multiple gene combination. There's the diathesis stress model, so people are genetically predisposed to have it. Then they encounter these stressors, and therefore it kind of activates this diathesis that's there. So, for example, that people get have the genetic predisposition, and then they have environmental exposure to stressors, and then it triggers the disorder, the schizophrenia, in vulnerable individuals. Um, there are high rates of genetic inheritance. We also see prenatal and obstetrical complications, so fetal hypoxia, so oxygen deprivation during birth. And there was a study, I believe it was one of the Scandinavian countries, and they found that women who got a certain virus while they were 4 to 6 months pregnant had a higher rate of giving birth to children who eventually developed schizophrenia. So it's kind of the critical stage in development, and having the flu during that period or other type of viral infection can potentially impact the child's um, future risk for schizophrenia. We also do find structural and functional abnormalities in the brain, such as enlarged ventricles, which are kind of the spaces in the brain, and decreased connectivity between brain regions. So here you'll see the genetic concordance rates with identical twins having almost 50%. I don't know if any of you have read Wally Lamb's book. I know this much is true, but it's about identical twins where one of them has schizophrenia. It's a very interesting book, both just as a read, but also kind of from a psychological perspective. Um, the children of patients who have schizophrenia almost also have a 50% risk. Fraternal twins, it's about 20%. So you can see that as the genetic relationship gets a little bit further, the chance of getting it is much less. But this points to a biological vulnerability. A lot of the medications that are used, antipsychotics, especially the old ones, target dopamine. So it was thought that the hallucinations and delusions in schizophrenia were caused by excessive levels of dopamine. So the medications they gave them blocked the dopamine receptors, and then they had the decrease in dopamine, which then resulted in the Parkinson-like symptoms. So there are also probably other neurotransmitters involved. So while this can work for some people, it's not necessarily the case for all of them. We also know we talked about emotional expression. So there is research to suggest that people who come from families where there's high levels of emotional expression, which means there's a lot of arguing, highly critical, they're overly emotionally involved, actually serve as stressors to those who have schizophrenia. Now, this might be something biological in that they are carrying genes that themselves kind of cause these types of behaviors, which then can set off the patient with schizophrenia. But we do know that those who live with families or in environments where there's lower levels of expressed emotion tend to have better outcomes. So we still are, learning a lot about schizophrenia. Are these all the same? I mean, there can be very different presentations. Are there multiple causes? Is there a heterogeneity of symptoms? What is the role of the environment and biology? The role of culture? Is there a continuum? And right now, in terms of medication, there is no cure. We have good success rates with antipsychotic medications in conjunction with psychosocial therapies, but they don't last forever, and oftentimes people go off their medications because there are serious side effects.